been my principles in surgery, neurosurgery, clean surgery, simple surgery, fast surgery. Preserve normal anatomy. This is extremely important principles, and I think this counts for every specialty. Do your work well. Thank you. And especially I have published and operated on a lot of cerebral aneurysms. So as mentioned, I have made my life work in Finland, working in 2 centers, in small city Kuopio, 17 years, and as a chairman in Helsinki, 18 years, where I retired 2015, and we have this collection of cerebrovascular cases in these 2 centers, more than 17,000 aneurysm patients with more than 22,000 aneurysms, and also a high number of cerebral AVMs were treated. I have operated many of them, as you can see, and in this way I have a large experience. We were also in eastern Finland, in Kuopio, the first ones in 90s, 25 years ago, to make randomized study on endovascular treatment and microsurgery. After that came the famous ISAT study and also the Phoenix Pratt study. Before coming to Henan, we planned a heart study, Henan aneurysm randomized study, because the number of aneurysms is here very high. But what I have seen now in 8 months, it seems practically very difficult to make this study because of the poor follow-up and some practice in the hospital. What we need to make randomized studies and to study the patients well after surgery, we need databases. And to plan databases is extremely easy, but to continue to make them well is extremely difficult. This is an example of the aneurysm database in Finland, so big number of cases, and this young female, Hanna Lehto, she used 7 years to make this database, and it continues now by one younger colleague, Recha Behnam Jahromi. So we need long-term follow-up to know the outcome of the treatment. If you publish in WeChat the same day your results, this is nothing. You have to see 1 year, more 10 years of your treatment. And this is how it was in Helsinki. Every neurosurgical center had their catchment area, and they were the only one to take the patients. I know here in China the patients are traveling from here, they go to Beijing, Shanghai, are treated there. In this big city, Chengzhou, you have at least two big neurosurgical centers. So the admission policy is completely different. So you don't know what happens with the patients, which patients are coming to you. So in Helsinki we had only one center, and we took all the patients from southern part of the Finland, and so we knew everything about every patient. Every patient came to us, and we could follow up the patients always. We had to take also a poor grade patient. This is a patient in intensive care, 99. So you see, this is old lady, 75 years old lady, severe subarachnoid hemorrhage, in respirator, difficult aneurysm, but I was treating with microsurgery this aneurysm, and this patient made good recovery. So in patients in grade 4, we had around 60% mortality, and in grade 5, 80%, but many of the patients, especially younger ones, survived to useful life. So what I always say as a microsurgeon, it is not the same to do open microsurgery in cerebral aneurysms. Even endovascular surgery is here extremely strong. So we continue. If you can do skilled microsurgery, you are doing well in treating aneurysms. But there's big competition. If open microsurgery wants to survive, we have to be good and efficient. We have to be both. And further, skills in open microsurgery may die without hard training. So continuous operative experience through the years is necessary. Otherwise you are not doing well. So once more, the principles of good microsurgery or endovascular surgery or whatever you are doing in your daily practice: plan well, clean and effective working. This is very important. Don't fool around in operation room or intensive care. This is important. And in operations, bloodless field means exact working. If there is a lot of bleeding, you cannot do well. So this is very important. Always try to work without bleedings. In Helsinki we didn't reserve any blood because the bleedings were minimal. So in Helsinki it was like a Silk Road, or all the people were coming to Helsinki, and I went everywhere in the world. So more than 3,000 visitors came in 18 years to Helsinki, and most days it looked like that in my operation room. Good possibility to change the clinical experience, and you see there is a world map in the corner. So everyone coming abroad put their needles there, and you see that also many Chinese people were coming there. So it's covering this. My picture is covering. Take out. So I had also many fellows from 6 months to 4 years. They were doing learning surgery, but also writing down papers. And one of the important things, many surgeons don't realize that you are not alone in the operation room doing surgery. So it is a teamwork in the operation room, like everywhere in the medicine. There are important players, but you should give respect to others. Anesthesia is extremely important in surgery, and you should not fight with the anesthetist. This means that you have a slack brain, making skull-base resection many times unnecessary. Brain compression is seldom, and brain destruction is also seldom. So this is one of the important things, and one of the important persons is also the scrub nurse here in Zhengzhou. With the time, we have 2 excellent scrub nurses in neurosurgery. They have learned the surgical language. You can speak the same language, English or Chinese, but if you don't understand the surgery, you cannot be good in helping the surgery. So this is extremely important. So one example from Helsinki. This is a Russian veterinary medicine with difficult aneurysm, basilar tip aneurysm. Was diagnosed in Burdenko Institute in Moscow, but was not treated there because they didn't do microsurgery or endovascular surgery for this aneurysm. So the patient came to Helsinki, and I treated this aneurysm by subtemporal approach. The patient was a couple of days confused, but after that made good recovery and went back home to Siberia to begin his work as veterinary medicine. So whatever we are doing in aneurysmal subarachnoid hemorrhage, there are late complications, and this is very important, because if you say that you have no vasospasm, you have never hydrocephalus, then you don't know what happens with the patients. So, to treat the vasospasm after aneurysmal subarachnoid hemorrhage, numerous medications have been tried. I think we once checked, the number was more than 800 different medications, last, magnesium, and so on. But no effective means are against the vasospasm. So, how to treat the patients? In poor grade patients, prolonged intubation with respiratory support, good oxygenation, and then we are giving triple H therapy, hypervolemia, hypertension. These remain the cornerstones of the treatment of severe aneurysmal subarachnoid hemorrhage. And since 80s, Professor Öhman made a randomized study on nimodipine in Helsinki. So after that, it was a tradition to treat the patients with nimodipine intravenous, or later we switched to peroral because it is by far cheaper the peroral nimodipine. But if the spasm is coming, the patient has deficits, then we go back to the intravenous nimodipine. So we are beginning here a trial going on in the world. There are nicardipine pellets, small pellets, we can put in surgery in the sylvian fissure, basal cisterns, and then this nicardipine is going in the CSF and preventing spasm. And this might be very good prophylaxis and treatment of spasm. It needs open microsurgery, and this will come now when we get the permission to do it with Hugo Andrade. So we have spasm. This is young lady. She had a basilar bifurcation aneurysm, and when I was traveling in Helsinki, she was coiled and was doing beautifully, walking around, and everybody was saying that why are we not coiling every aneurysm? But what happened? She get headaches, developed hemiparesis, became unconscious, and died. This is what happens with the spasm. You cannot prevent everything. So, in our database, large number of patients, 2% of the patients die in vasospasm, and 17% have severe invalidity. And this is extremely important. So we have to find effective means to prevent deaths and deaths and disability by vasospasm. So, why microsurgery is going down, especially in aneurysm treatment? There is deep cap, fear, lack of skills. The younger neurosurgeons are not well trained or doesn't want to train well, and then there is a love of comfort. It is more easy to do the surgery daytime than in the nights or evenings. Treating the aneurysm wall is the most important factor. If the wall is calcified or thick, it is more difficult to go from outside to compress the walls together with a clip. So this is very important. So in difficult aneurysms, you should have intraoperative angiography, and here in Henan we have good hybrid rooms. It is possible. It's possible to work together. So if you have that kind of aneurysm, calcified aneurysm, of course you cannot clip or resect that. You have to do a bypass to treat this MCA aneurysm, and it was done. And in the same way, here is a giant middle cerebral artery aneurysm in a JUHA witness. It was resected and clipped, and special for the JUHA witnesses is that they don't accept any blood transfusion, and we didn't give any blood, so it was operated without blood. And this is intraoperative angio with primitive C-arm. So here in Henan you have more beautiful facilities, hybrid room. But you see that the in angio the aneurysm is resected, exactly clipped, and take a look on the flap. Flap is big, respecting the big lesion. So I have counted in my mind, correct if I'm wrong. This is China population, 1,400 million people, big population. So according to our knowledge, around 2.5 to 3% of the people are carrying an aneurysm. This means that 40 million Chinese are carrying cerebral aneurysms. So to treat all of them, I know that pipeline is 220,000 RMB, and the number clip is around 3,000 RMB. So to treat all these Chinese people, you cannot do always endovascular, because then China would go down. You would spend too much money for this simple disease. You have many diseases in this world, but one thing is important. If you think of the nation, so some treatment is very expensive and you cannot give it to everybody. This one we see all the time. The indication for treatment of aneurysms are paramedical, not really medical. So I was working with Fitri last year in Nepal. We saw that the patient didn't have money for a clip. They went home, left against medical advice, LAMA, because they didn't have money for a clip. This is 3,000 RMB. So world is different. So we have to think also about the economical things. It is not inside the hospital where everything is happening. Outside the hospital, many selections are done. So to speak about difficult cases, I have the saying, desperate cases need desperate treatment. You will fail many times in deeply unconscious patients, but sometimes you have wonderful results, like miracles in a huge hospital, like Henan Provincial People's Hospital is difficult because the hospital is so big, so you cannot manage with the time. I'm wondering how they are doing with the intra-arterial thrombolysis in thrombosis, because the time is so important. In a small city, Helsinki, many patients came within 2 hours and had already thrombolysis. But here it takes time, traffic is terrible and more difficult to come inside. So this Henan Provincial People's Hospital is like a big ocean ship, very difficult to turn fast. So this is a patient from Helsinki, 28 years old male, on Monday morning, Monday afternoon, 3 bleedings, and then 6 o'clock in the afternoon. So she had 4th bleeding, both pupils blowed up and were wide dilated. We saw in CT this hematoma and anterior communicating aneurysm. I gave mannitol. In 2-3 minutes we were inside the operation room. I took the hematoma out and clipped the aneurysm, and the patient made a recovery like miracle. He's not able to work, but he's able to take care of his 3 children. He's a good father for them, and this is something very special. Both pupils dilated, so we had a very quick route to operation room. Another case, 2002, this 9 years old girl was diagnosed of this deep AVM. Of course you cannot operate on that. To do something we gave radiosurgery. But what happened? 2011, 9 years after diagnosis, she had headache, became unconscious, had left hemiparesis, pupil dilated, had this hematoma, and in CT angio, terrible central AVM. So I went to take the hematoma out, and when I opened, so all the blood of Helsinki was coming out. But I could make hemostasis, but the next day patient was deeply unconscious, hematoma even bigger, and both pupils dilated. So I operated this 4 times. I operated this AVM, and after 4 operations I could take it out all in control angiograms, clean result. And now the patient, unfortunately I don't have the picture of her, but she has severe left hemiparesis, left arm totally paralyzed, but she has studied and she's able to work. So certainly life was saved. Here is the picture of the girl. And like many young females, they have tattoos in their legs. You see, she has taken tattoo in the right moving leg. Left leg is, but she is able to work and has studied a good profession for her. So this is she 5 years, 6 years later. So, and then another case, one more case. This is a girl, 9 years old, came in April 2001, like from a concentration camp, cachectic, tetraparetic, contractors, and had this deep brainstem cavernoma. The nurses and my colleagues said, you cannot operate on because she is too weak for anesthesia, but I went to operation room because I'm a stubborn person and took this cavernoma out by subtemporal route, and she made recovery like miracle. Here 1 year later, now she's a teacher and has 2 or 3 children in Estonia, southern of Finland. So beautiful recovery. So these kind of things give you power to continue neurosurgery. You should always think, can we do something to this lesion, not turn your back to the lesion. You should always think, is it possible to do something for this lesion? Because these are terrible lesions and they may kill or disable the patients. So we should analyze our complications, and this is one of the important sentence from Dr. Drake, my teacher. If we could make a second time in the operation room when we failed, seldom we get the second chance. In neurosurgery it is usually only one time, but sometimes you have a second chance and you can correct your failures. But this is important. You should always analyze your difficult cases, your complications. Otherwise you are not learning. If you just publish in WeChat your beautiful cases, this is nonsense. So you should publish your difficult cases. So about endovascular surgery, I told you it is expensive. So only 5/6 of the world population has access, no access to endovascular treatment, so it is seldom. And what about the results in AVM surgery? Treatment of AVMs, this is a meta-analysis by Leo X. So with microsurgery 96% occlusion rate, radiosurgery 38 and embolization 13, even the best endovasculars claim that they are doing better, but this is selection of the cases. So this is the Finland long-term follow-up study of AVMs since Second World War. Longest follow-up is 70 years. 70 years, not in this paper that was published 15 years ago, but you see that the best outcome is in AVMs if they are totally occluded, and conservative treatment of the AVMs gives very poor outcome, especially in the most difficult cases, especially Martin 4 and 5. And between them is partial occlusion. It is from the historical series when the feeders were occluded by open microsurgery, not coming from the... If you embolize AVM partially, so the bleeding risk is 3 times higher than without embolization. This is our study from Finland with extremely long follow-up. Like you see here, average 29, 30 years. What about brain tumors? In brain tumors, microsurgery continues, but there are strong results in microsurgery, and these are especially in skull-based tumors, endoscopic surgery. You are doing beautifully in cellular tumors, hypophyseal tumors, and many other extracranial tumors, and it is coming also inside the skull, but also radiosurgery. Stereotactic radiosurgery is taking its part on the difficult skull-based tumors. What about brain injuries? Brain injuries should be treated in special trauma centers. You should have special skills for hemicraniectomy, but for also the new therapy for the cisternostomy that was developed by Professor Cherian in Nepal. You go to basal cisterns, open them, and then you have a slack brain without hemicraniectomy. This is very important. We should learn that. Even the number of trauma cases is low in Henan Provincial People's Hospital, certainly also at the University Hospital, so the trauma cases are treated somewhere else, but we should learn. But how to treat the best way traumas? So the prevention remains the best treatment, and this is extremely important to understand. So in Finland, when I began my neurosurgery in 1973, so all the time young motorbike drivers, car drivers were coming unconscious, dying to the emergency department, and we treated them. But 1,300 deaths a year. Now, with heavy traffic, of course the traffic is now 3 times more, but we have only 250 deaths in traffic. So this is the best way to treat the patients, not to increase the number of intensive care, but to have speed limits, safety belts, respect of red lights and pedestrians, no drunken driving. I know this has been affected now heavily in China, but you need a totally different traffic culture. Traffic is here terrible. There is no respect to those who are crossing the routes. So, in brain injuries, prevention remains the most effective treatment. If you increase the number of intensive care beds, it has nothing good to do. You should prevent terrible brain contusions, thorax injuries, abdominal injuries. It might be nice to treat them, but the patients are never the same than before the injury. So I think China is a very strong country and can prevent injuries, and this needs paramedical politicians to treat this thing, and this is the best treatment. So what about spine surgery? I think in future all the foreign material that is now implanted so in huge masses, huge amounts, because spine surgery is a big business. You implant something and then you get a lot of money. So the prevention of spinal traumas remains also effective treatment, and we are beginning very important studies in spinal injury now with Dutchman Semmar at Henan Provincial People's Hospital. Research is beginning international research. So what is the future? I was working with Drs. Drake and Peerless. We wrote 1996, this is 23 years ago. We wrote that we should identify the aneurysms before rupture, so we can treat them before subarachnoid hemorrhage, because aneurysma subarachnoid hemorrhage is a fatal disease. 50% die, whatever we are doing outside of the hospital. So if we can treat these aneurysms with some means or prevent them, this is the best treatment, and biological solutions are coming, especially in AVMs, but also in aneurysm. This is our basic research has been. And it is important to train in bypasses, because this makes you better neurosurgeon. I have to say that we made a small study in Finland on moya disease, small number of patients, 60 in both both categories, but moja disease is extremely rare in Finland, not as compared here. It is extremely common. I see every week many moja bypasses. In Finland, with long-term 10 years follow-up, we didn't find any difference in the surgical cases or conservative cases, so it is interesting. We want to study also moja disease here, what is the cause of that. I'm coming soon to end, sorry. So I heard always in the congresses, endovascular congresses, that next year better technology will help us in serving our patients better. Of course, better technology is important. So we were thinking something, and then we developed this slow closing clip, JUHA H clip, which is good to treat these monstrous atherosclerotic vertebrovascular aneurysms. It has a patent, but unfortunately we cannot find anyone to do it. So if you have connections with the Chinese technology, take contact with me, so we would love to have this clip done in higher amounts, because in China you have many of them. Dr. Reza Yahrami is making his PhD in Helsinki on 519 monstrous aneurysm. This is an extremely good PhD book. It is a breakthrough in medicine. So how could we make this clip? With our neurosurgical team and then 2 watchmeets. 2 watchmeets, they are doing watches, and they are expensive. So you have to pay 40,000-50,000 euros or dollars for one watch. But they are nice and beautiful, of course. But these guys are clever, they have good thinking, and they have now developed a new bypass. Only 1 minute for the bypass. This is important. So this is slow closing clip, primitive form. A Norwegian young patient was treated this way with, don't explain how the clip is done. Future is complex. Future in short term, 5 to 10 years. Functional neurosurgery will increase, pain will be treated in China heavily, and whole population will be treated. This is important. And future in long term, 20 years, malignant gliomas, less surgery, effective treatment will be developed for this terrible disease. Brain tumors, more endoscopy, aneurysms and AVMs, increase in endovascular treatment, but finally biological treatment. In traumas, prevention, spinal surgery, less instrumentation, functional neurosurgery, pain and movement disorders, huge increase, and of course artificial intelligence and robotics are coming in heavy way. So this is once more the slide in Chinese. So, 谢谢你。